Normal elimination of urinary waste is a function that affects all body systems. Patients with alterations in urinary elimination may suffer emotionally from body change. This slide is merely a review of your anatomy and physiology on the urinary system. The kidneys lie on either side of the vertebral column behind the peritoneum and against the deep muscles in the back. Kidneys filter waste products of metabolism that collect in the blood. The blood reaches each kidney by a renal or kidney artery that branches from the abdominal aorta. The nephron, the functional unit of the kidney, which is the picture on the right, forms the urine. It is composed of the glomerulus, Bowman's capsule, proximal convoluted tubule, the loop of Henle, the distal tubule, and the collecting duct. Ureters or ureters are tubular structures that enter the urinary bladder. Urine draining from the ureters to the bladder is usually sterile. The ureters enter obliquely through the posterior bladder wall. This arrangement prevents reflux of urine from the bladder into the ureters during the act of micturition by compression of the ureter at the ureterovesicular junction. An obstruction within the ureter, such as the kidney stone, or called the renal calculus, results in strong peristaltic waves that attempt to move the obstruction into the bladder. These waves result in pain, often referred to as renal colic. The urinary bladder is a hollow, distensible muscular organ, the detrusor muscle, that stores and excretes urine. When empty, the bladder lies in the pelvic cavity behind the symphysis pubis. In men, the bladder lies against the anterior wall of the rectum, and in women, it rests against the anterior walls of the uterus and vagina. A patient with a long-standing history of diabetes mellitus is voicing concerns about kidney disease. The patient asks the nurse where urine is formed in the kidney. The nurse's response is A. Bladder, B. Kidney, C. Nephron, D. Ureter. And the answer is C. Nephron. In addition to filtering blood and creating urine, the kidneys have other amazing functions. They produce several substances vital to red blood cell production, blood pressure, and bone mineralization. They're responsible for maintaining a normal RBC volume by producing erythropoietin. Erythropoietin functions within the bone marrow to stimulate RBC production and maturation and prolongs the life of mature RBCs. Patients with chronic kidney conditions cannot produce sufficient quantities of this hormone, and therefore they are prone to anemia. The kidneys affect calcium and phosphate regulation by producing a substance that converts vitamin D into its active form. Patients with chronic alterations in kidney function do not make sufficient amounts of the active vitamin D. They are prone to develop renal bone disease resulting from the demineralization of bone caused by impaired calcium absorption. The physiological effects of the renin-angiotensin mechanism are shown in this diagram. Renin functions as an enzyme to convert angiotensinogen, a substance synthesized by the liver, into angiotensin I. Angiotensin I is converted to angiotensin II in the lungs. Angiotensin II causes vasoconstriction and stimulates aldosterone release from the adrenal cortex. Aldosterone causes retention of water, which increases blood volume. The kidneys also produce prostaglandin E and prostacyclin, which helps maintain renal blood flow through vasodilation. These mechanisms increase arterial blood pressure and renal blood flow. Voluntary control from higher brain centers and involuntary control from the spinal cord influence the act of micturition or voiding. Brain structures that influence bladder function, cerebral cortex, the thalamus, the hypothalamus, and the brainstem, inhibit the urge to void or allow voiding. Normal voiding requires the contraction of the bladder and coordinated relaxation of the urethral sphincter and pelvic floor muscles. It's vital that nurses understand the process of normal voiding to be able to assess and determine which form of incontinence or which bladder problem may be occurring. Bladder capacity varies with the individual but ranges from 600 to 1,000 mils of urine. An adult normally voids every 2 to 4 hours. As the volume increases, the bladder walls stretch, sending sensory impulses to the micturition center in the sacrospinal cord. Incontinence is classified as functional, overflow, stress, urge, or total. Each type has specific nursing interventions. Damage to the spinal cord above the sacral region causes reflex incontinence. This condition causes loss of voluntary control of urination, but the micturition pathway often remains intact, allowing urination to occur without sensation of the need to void. If a chronic obstruction caused by neurological damage, such as prostate enlargement, hinders bladder emptying, over time the micturition reflex changes, causing bladder overactivity and possibly causing the bladder not to empty completely. Overflow incontinence occurs when the bladder is overly full and the bladder pressure exceeds sphincter pressure, resulting in involuntary leakage of urine. These causes are often head injury, spinal injury, multiple sclerosis, diabetes, trauma to the urinary system, and post-anesthesia sedative hypnotic tricyclics and analgesia. So you can see what a difference medications can make. Hyperreflexia, a life-threatening problem that affects heart rate and blood pressure, is caused by an overly full bladder. It is usually neurogenic in nature. However, it can be caused functionally by blockage. Socioeconomic factors will determine the degree of privacy needed for urination. Psychological factors include anxiety and emotional stress and privacy issues. The kidneys primarily maintain the balance between retention and excretion of fluid. Symptoms common to urinary disturbances include frequency, urgency, dysuria, polyuria, oliguria, incontinence, and difficulty starting the urinary stream. If you're unfamiliar with those terms, nocturia, polyuria, oliguria, anuria, diuresis, you might want to look those up. Disease processes that affect urine elimination affect renal function, changes in urine volume or quality, the act of urine elimination, or both. Conditions that affect urine volume and quality are generally categorized as pre-renal, renal, or post-renal in origin. Decreased blood flow to and through the kidney, or pre-renal, disease conditions of the renal tissue, renal, and obstruction in the lower urinary tract that prevents urine flow from the kidneys, post-renal, sometimes alter renal function. Conditions of the lower urinary tract, including narrowing of the urethra, altered innervation of the bladder, or weakened pelvic and perineal muscles, affect urinary elimination. Diabetes and neuromuscular diseases such as MS cause changes in nerve functions that can lead to possible loss of bladder tone, reduced sensation of bladder fullness, or inability to inhibit bladder contractions. Older men often suffer from BPH, or benign prostatic hyperplasia, which makes them prone to urinary retention and incontinence. Some patients with cognitive impairment, such as Alzheimer's disease, lose the ability to sense a full bladder or are unable to recall the procedure for voiding. Diseases that slow or hinder physical activity interfere with the ability to void. Degenerative joint disease and Parkinsonism are examples of conditions that make it difficult to reach the toilet facilities. Diseases that cause irreversible damage to kidney tissue result in end-stage renal disease, or ESRD. Eventually, the patient has symptoms resulting from uremic syndrome, an increase in nitrogenous waste in the blood, marked fluid and electrolyte abnormalities, nausea, vomiting, headache, coma, and convulsions characterize this syndrome. Indications for dialysis include renal failure that can no longer be controlled by conservative management, worsening of uremic syndrome associated with ESRD, which would include nausea, vomiting, neurological changes, and pericarditis, and severe electrolyte and/or fluid abnormalities that cannot be controlled by simpler measures. Preoperative orders if nothing by mouth or an underlying disease condition affects fluid balance before surgery. This reduces urine output. In addition, the stress response releases an increased amount of ADH, which increases water resorption. Stress also elevates the level of aldosterone, causing retention of sodium in water. Both of these substances reduce urine output in an effort to maintain circulatory fluid volume. Anesthetics and narcotic analgesics slow the GFR, reducing urine output. These pharmacological agents also impair sensory and motor impulses traveling among the bladder, spinal cord, and brain. Patients are often unable to sense bladder fullness and initiate or inhibit micturition. Spinal anesthetics, in particular, create the risk of urinary retention because of inability to sense the need to void and possibly the inability of the bladder muscles and urethral sphincters to respond. Surgery of the lower abdominal and pelvic structures sometimes impairs urination because of local trauma to surrounding tissues. After returning from surgery involving the ureters, bladder, urethra, patients routinely have urinary catheters. Many medications directly or indirectly contribute to urinary dysfunction. Antipsychotics, antidepressants, alpha-adrenergic agonists, and calcium channel blockers can cause urinary retention and overflow incontinence. Alpha-antagonists, diuretics, sedative hypnotics, opioid analgesics, ACE inhibitors, and antihistamines can cause urinary incontinence. Anti-Parkinson medications may cause urinary urgency and subsequent incontinence. Always consider these medications as the cause of new onset urinary incontinence, especially in older adults. Some medications may change the color of urine. For example, pyridium colors the urine a bright orange to rust. Amitriptyline causes a green or blue discoloration, and levodopa discolors the urine brown to black. Cancer chemotherapy drugs also color the urine and are often toxic to the bladder or kidneys. Patients with impaired kidney function require dosage adjustments in medications excreted by the kidneys. Examination of the urinary system influences micturition. Some procedures, such as an IVP, require patients to limit fluids before a test. A restriction in fluid may commonly lower the urine output. Diagnostic examinations like cystoscopy, involving direct visualization of the urinary structures, causes localized edema of the urethral passageway and spasm of the bladder sphincter. After the procedure, a patient may have difficulty voiding or may have red or pink urine caused by trauma to the urethral or bladder mucosa. As urinary retention progresses, retention with overflow develops. Bladder distension is apparent. With retention, the patient may void small amounts of urine 2 to 3 times an hour with no real relief. UTIs are usually caused by E. coli. Bacteria in the urine leads to the spread of organisms into the kidneys and possibly into the bloodstream. Microorganisms commonly enter the urinary tract through the ascending urethral tract. Bacteria inhabit the distal urethra, the external genitalia, and the vagina in women. Women are more susceptible to infection because of a short urethra and close proximity to the anus. Burning during urination is known as dysuria, as urine passes through inflamed tissues. An irritated bladder is known as cystitis. Irritation of the bladder and urethral mucosa causes hematuria. If infection spreads to the kidneys, pyelonephritis occurs, with symptoms of flank pain, tenderness, fever, and chills. Urinary incontinence can be a temporary or permanent condition and continuous or intermittent. Urinary incontinence can affect patients of any age, but is very prevalent in the elderly. Causes can include problems with movement, removing clothing, and mental incapacity. Some patients may have a urinary stoma to divert the flow of urine from the kidneys to the external source. This may be necessary because of trauma, cancer, radiation, a fistula, or chronic cystitis. The types of diversion include ileal loop or conduit, continent pouch, and nephrostomy. Provide frequent opportunities to void. Older adults have a small bladder capacity than younger adults. Encourage older adults to empty the bladder completely before and after meals and at bedtime. Discourage drinking coffee, tea, brown cola, and alcohol because these have a diuretic effect and increase urinary frequency. Make fluids such as cranberry juice available as part of the patient's fluid intake. Cranberry juice and vitamin C help acidify the urine to decrease bacterial infections of the bladder. Restricting fluid intake does not decrease urinary incontinence severity or frequency. Avoid the routine use of indwelling catheters. If one is necessary, use it no longer than necessary. The risk of infection increases dramatically for catheterized patients. Note that incontinence is not a normal part of aging, and make efforts to assess incontinence and provide interventions to promote return to continence. See box 45-2 on page 1048. Focus on older adults promoting urinary health. Conditions such as bladder cancer, radiation, injury to the bladder, and chronic urinary infection may necessitate a urinary diversion to drain urine from a diseased or dysfunctional bladder. There are two types of continent urinary diversions that can be performed. A continent urinary reservoir is created from a distal portion of the ileum and a proximal portion of the colon. The ureters are embedded in the reservoir. This reservoir is situated under the abdominal wall and has a narrow ileal segment brought out through the abdominal wall to form a small stoma. The ileocecal valve creates a one-way valve in the pouch through which a catheter is inserted to empty the urine from the pouch. Patients must be willing and able to catheterize the pouch 4 to 6 times a day for the rest of their lives. The second type is an orthotopic neobladder that uses an ileal pouch to replace the bladder. Anatomically, the pouch is in the same position in which the bladder was before removal, allowing patients to void normally. Incontinent urinary diversions are less commonly performed. Surgery involves connecting the ureters to a section of the intestinal ileum with formation of a stoma on the abdominal wall. Urine drains continuously because the patient has no sensation or control over urinary output, requiring the application of a collection pouch at all times. Some patients need urinary drainage directly from one or both kidneys. In this case, a tube is placed directly into the renal pelvis. This procedure is called a nephrostomy. Any urinary diversion poses threats to a patient's body image. The patient must learn how to manage the diversion, and those who do not have a continent urinary diversion must wear an artificial device at all times. However, most patients are able to wear normal clothing, engage in physical activity, travel, and have sexual relations. Care must be taken not to pull on tubing, especially with a nephrostomy, because it can be pulled out, causing tissue and organ damage and infection. Most nephrostomies are sutured into the kidney. Refer patients with a urinary diversion to an ostomy nurse. This specialist is a valuable resource for assisting the patient and family with matters pertaining to all aspects of care. The ostomy nurse often meets with the patient and family before surgery. In addition, refer the patient to the United Ostomy Associations of America, This organization provides information about support groups to enhance coping and adaptation to lifestyle and body changes. Recall that for many, the act of urinary elimination is a private process. Students need to be cognizant of the many issues affecting this process. The urinary tract is sterile. The use of infection control principles will help prevent the spread of UTIs. Increased fluid intake results in increased diluted urine formation, which reduces the risk of urinary tract infection. Growth and development factors will determine the patient's ability to control the active urination across the lifespan. Infants, children, and the elderly experience problems with urination. The young need to learn to recognize the need to urinate. The elderly need to deal with the decreased functioning that accompanies aging. Weak abdominal and pelvic floor muscles impair the ability of the urinary sphincter to maintain tone. Immobility, muscle damage during vaginal delivery, and muscle atrophy or trauma contribute to problems with urination. Psychosocial issues such as body image, self-esteem, roles, and identity may influence urination. Gender differences also occur. Males stand where females sit. Culture influences the act of urination. Urinary problems may not be treated in the Western tradition. Culture may also dictate how and when a patient urinates. In some cultures, patients urinate in a squatting position. It will be important to render culturally competent care. Nursing history includes a review of elimination patterns, symptoms of alterations, and other factors. Box 45-4 on page 1051 presents nursing assessment questions to ask. Table 45-1 presents common types of urinary alterations. Be sure to look at both of those. Factors that affect urinary alteration include environmental factors, medication history, psychological factors, muscle tone, fluid balance, current surgical or diagnostic procedures, and the presence of disease. It often helps to offer the child fluid 30 minutes before requesting a specimen. You need to use terms for urination that the child is able to understand. A young child is often reluctant to void in unfamiliar receptacles. A potty chair or specimen hat placed under the toilet seat is usually effective. You'll need to use special collection devices for infants or toddlers who are not toilet trained. You can attach a clear plastic, single-use bag with self-adhering material over the child's urethral meatus. Do not obtain specimens by squeezing urine from the diaper because the results will be inaccurate. Your knowledge, experience, standards, and attitudes will play critical roles in the assessment process. Apply the nursing process and use critical thinking approaches in the care of patients. The nursing process provides a clinical decision-making approach by which you can develop and implement an individualized care plan. During the assessment process, thoroughly assess each patient and critically analyze findings to ensure you make patient-centered clinical decisions required for safe nursing care. Successful critical thinking requires synthesis of knowledge, experience, information gathered from patients, critical thinking attitudes, and intellectual and professional standards. Clinical judgments require you to collect necessary information, analyze the data, and anticipate and make decisions regarding care. To identify a urinary elimination problem and gather data for a care plan, use scientific and nursing knowledge, conduct a nursing history, perform a physical assessment, assess the patient's urine, and review information from diagnostic tests and examinations. Skin and mucosa. Assess the skin's hydration by looking at turgor and texture. Kidneys. Nurses with advanced skills learn to palpate the kidneys. Bladder normally sits below the symphysis pubis. Gentle palpation on a distended bladder causes the patient to feel tenderness, pain, or the urge to urinate. Percussion produces a dull tone. The female will need to lie in the dorsal recumbent position to expose the genitalia to examine the urethral meatus. Using gloved hands, retract the labia to observe the urethral meatus. Look for drainage or lesions and ask the patient if this is uncomfortable. Drainage indicates infection. The male's meatus is normally a small opening at the tip of the penis. Inspect the meatus for discharge, lesions, and inflammation. For the uncircumcised patient, you will need to retract the foreskin. In this skills lab, we talked about how to measure and document I&O. Remember that hourly output of less than 30 mils for longer than 2 hours is cause for concern and further assessment. The color of urine should be pale straw to amber. Urine will be more concentrated in the morning, and medications can change the color, as can some foods. Dark amber urine is the result of bilirubin from liver disease. Stagnant urine has a strong ammonia odor. A sweet, fruity odor is seen with diabetes or starvation. You will learn how to collect specimens in your clinical experiences. These specimens can be random, clean, voided or midstream, and sterile or timed, and we talked about some of those in lab. To analyze a urine sample, you must collect it correctly. Refer to your specific healthcare facility for policies and procedures. Table 45-3 on page 1054 lists normal values for a urinalysis. Specific gravity is the weight or degree of concentration of a substance compared with an equal volume of water. When collected properly, a clean voided urine specimen does not contain bacteria from the urethral meatus. A urine culture requires a sterile or clean voided urine sample. It will take 24 to 48 hours to reveal the findings of bacterial growth. The test for sensitivity will determine which antibiotic will be most effective. Non-invasive examinations include a KUB, which is actually an abdominal film or x-ray of the kidneys, ureter, and bladder, a CT, or an IVP. Invasive examinations include cystoscopy and arteriography. Remember that each examination has specific indications and uses, bowel preparations, and patient education. Some examinations will require a signed consent form. Some will require the injection of dye, and you need to assess the patient's sensitivity to that dye. When you measure urine from a drainage bag, a separate plastic graduated measuring receptacle is used to obtain more precise measurement of urine output. Each patient needs to have a graduated receptacle for his or her exclusive use to prevent potential cross-contamination. Label each container with the patient's name. The container needs to be rinsed after emptying, and the tubing that drains the bag securely clamped and cleaned with alcohol before it's put back into the holder. Report any extreme increases or decreases in urine volume. An individual's daily output generally ranges from 12 to 1,500 mils of urine. Hourly output of less than 30 mils for longer than 2 consecutive hours is cause for concern. Similarly, you need to report consistently high volumes of urine or polyuria, over 2,000 to 2,500 mils per day. The nurse collects random, clean, voided, or midstream, sterile, and timed specimens. The method of collection varies according to the patient's developmental level and the specimen ordered. Here you see a care provider checking the results of a chemical reagent strip dipped in urine. For a quick screening, perform certain portions of the urinalysis with special reagent strips. Dip the strips into the urine and observe for a color change and the time interval designated on the package. Some nursing diagnoses common to patients with urine elimination alterations are shown here on the slide. A general goal is often normal urinary elimination, but sometimes the individual goal differs depending on the problem. Consider the patient's home environment and normal elimination routines when planning therapies. Collaborate with several healthcare disciplines, the patient and the patient's family. Maintaining normal urinary elimination helps to prevent many urination problems. Many nursing measures promote normal voiding in patients at risk for urinary difficulties and in those with established urination problems. Methods of promoting the micturition reflex help patients sense the urge to urinate and control urethral sphincter relaxation. A patient's ability to void depends on feeling the urge to urinate, being able to control the urethral sphincter, and being able to relax during voiding. Help patients learn to relax and stimulate the reflex to void by helping them assume the normal position for voiding. A woman is better able to void in a squatting or sitting position. If the patient is unable to use toilet facilities, position him or her in a squatting position on a bedpan or bedside commode. Other measures that promote relaxation and the ability to void include sensory stimulation. The sound of running water helps many patients void through the power of suggestion. Stroking the inner aspect of the thigh stimulates sensory nerves and promotes the micturition reflex. You can also pour warm water over the patient's perineum and create the sensation to urinate. If you need to measure urine output, first measure the volume that you're going to pour over the perineal area. Integrating patients' habits into the care plan fosters normal voiding and helps prevent problems related to urination. A simple method of promoting normal micturition is maintaining optimal fluid intake. Encouraging patients to wait until urine stops flowing or to attempt to void again can improve bladder functioning. One of the most important considerations is to prevent the infection of the urinary system. A man voids more easily in the standing position. If the man cannot reach toilet facilities, have him stand at the bedside and void into a urinal, such as the one shown here. At times, it is necessary for one or more nurses to help the man stand. Patients usually require time to void. Requesting a urine specimen on demand does not contribute to relaxation and normal voiding habits. Give patients at least 30 minutes to provide a specimen. Many patients need privacy for voiding. If a patient cannot reach the bathroom and uses a bedside commode or bedpan, make sure that the bedside curtain is closed. Drug therapy given alone or with other therapies often helps problems of incontinence or retention. The bladder is innervated by the parasympathetic nervous system. Drugs that block the muscarinic receptors suppress bladder contractions and reduce incontinence caused by bladder irritation. When the bladder empties, the detrusor muscle contracts in response to parasympathetic stimulation. Incomplete bladder emptying results from impaired innervation or weakness of the detrusor muscle. The patient experiences retention and possible overflow incontinence. Cholinergic drugs increase contraction of the bladder and improve emptying. Catheterization of the bladder involves introducing a latex or plastic tube through the urethra and into the bladder. The catheter provides continuous flow of urine in patients unable to control micturition and in those with obstructions. Catheterization involves introducing a tube through the urethra into the urinary bladder. This procedure can cause UTI, blockage, and trauma to the urethra. Box 45-7 on page 1061 presents indications for catheterization. Be sure you look at that. Catheterization can be intermittent or indwelling. A catheter drainage system should be a closed system positioned to allow free drainage by gravity of the urine. You need in order to insert a catheter. You must use sterile aseptic technique. After inserting a indwelling catheter, maintain a closed urinary drainage system to minimize the risk of infection. Sites for breakage in the system include the drainage bag, spigot, the bag juncture, the junction of the tube, and bag. Most drainage bags contain an anti-reflux valve to prevent urine in the bag from re-entering the drainage tubing and contaminating the patient's bladder. Follow specific guidelines for catheter selection so the catheter does not cause harm. Nurses provide perineal hygiene at least 3 times daily or as needed for a patient with a retention catheter. You'll need to check your healthcare facility's policies and procedures for catheter care. All patients with catheters should have a daily intake of 2,000 to 2,500 mils if permitted. Catheter irrigations and installations can be used to maintain the patency of an indwelling urinary catheter. Blood, pus, or sediment can collect in the tubing, causing bladder distension and buildup of urine. An indwelling urinary catheter remains in the bladder for an extended period, making the risk of infection greater than with intermittent catheterization. When removing an indwelling catheter, promote normal bladder function and prevent trauma to the urethra. Suprapubic and condom catheters are 2 alternatives to indwelling catheters. Suprapubic catheterization requires a surgical placement of a catheter through the abdominal wall above the symphysis pubis and into the urinary bladder. Maintenance of the tubing and bag is the same for an indwelling catheter. A condom catheter is used for male patients only. Box 4511 shows you the procedural guidelines for a condom catheter. Intermittent and indwelling retention catheters are 2 forms of catheter insertion. With the intermittent technique, you introduce a straight single-use catheter long enough to drain the bladder. When the bladder is empty, you immediately withdraw the catheter. You can repeat intermittent catheterization as necessary, but each insertion increases the risk of trauma and infection. It's common for people with spinal cord injury and other neurological problems such as MS to perform self-intermittent catheterization up to every 4 hours daily for months or years. If done correctly with the use of clean technique, they frequently do not experience more UTIs. In fact, the UTI rate is lower for patients with long-term indwelling catheters. An indwelling or Foley catheter remains in place for a longer period, until the patient is able to void voluntarily or until continuous accurate urine measurements are no longer needed. The second type of intermittent catheter has a curved tip. A Coude catheter is used on male patients who may have enlarged prostates that partially obstruct the urethra. It is less traumatic during insertion because it is stiffer and easier to control than the straight tip catheter. Catheters are available in many diameters to fit the size of a patient's urethral canal. Box 45-8 on page 1062 provides suggestions on how to make appropriate decisions regarding catheter selection. Figure 45-13 on page 1063 in your text shows potential sites for introduction of infectious organisms into a urinary drainage system. Be sure that you take a look at that. The condom catheter is suitable for incontinent or comatose men who still have complete and spontaneous bladder emptying. It is a soft, pliable latex sheath that slips over the penis. Patients wear it only at night or continuously depending on their needs. This procedure can be delegated to nursing assisted personnel. as it's important to be sensitive to the privacy needs of patients. Be sure that the skin of the penile shaft is intact and free from swelling, redness, or open lesions before applying the condom catheter. For a man with a retracted penis, a conventional condom catheter often proves difficult. Special devices are available to help alleviate this problem. No collection devices for women are as effective as the condom catheter is for men. Thus, frequently the only devices used are pads and protective clothing. To maintain dignity, do not refer to pads and protective clothing as adult diapers and change them frequently to control odor. Use these products only temporarily to minimize or prevent episodes of incontinence while treatment is ongoing. Monitor patients frequently and provide good skin care to prevent irritation caused by urine. Some manufacturers have developed a female urinal, however, its ease may be an issue. The patient is the best source of evaluation of outcomes and responses to nursing care. Note the patient's responses to questions about urination. Does he or she seem hesitant or embarrassed? Psychosocial factors such as culture or sexuality sometimes influence the patient's response. Because urination is often considered a private matter, some people find it difficult to talk about their voiding habits. Remember that urinary elimination problems are not just physiological in nature. Be sensitive to any changes in self-concept and sexuality. Self-concept, which includes body image, self-esteem, roles, and identity, develops over a lifespan. Because the penis is an organ for both urination and sex, urinary dysfunction often greatly affects the man's self-concept. What are some examples of questions to ask during the evaluation step? Maybe, tell me, how frequently are you voiding now? Do you continue to have the feeling of urgency every time you void? Have the symptoms of urgency decreased since you changed your caffeine intake? Ensuring patient safety is an essential role of a professional nurse. To ensure patient safety, communicate clearly with members of the healthcare team. Assess and incorporate the patient's priorities of care and preferences, and use best evidence when making decisions about your patient's care. When performing the skills in this chapter, remember the points on the slide to ensure safe, individualized patient care.